Without further ado, thank you all for joining. Thank you, Cynthia O'Neal and Denise Neill. We're so glad to have you. Take it away.
Well, good morning. I am Denise Neill. I am from Texas A&M University-Commerce, and I also work with the AACN Organizational Leadership Network. And I'm also working with the pilot groups that are piloting the 10 schools that are piloting the essentials development. And Cynthia and I have known each other for several years. So when I was asked to present, I started researching and found out she is very knowledgeable about competency-based and AACN. So I invited her to join me.
Thank you, Denise. I am Cynthia O'Neal. I am the Associate Dean for Undergraduate Studies at UT Health San Antonio School of Nursing. I am also involved in several of the initiatives being put forth by AACN related to competency-based education. And I'm so happy to be here to discuss this today. So thank you, everyone, for having us. A little bit of technical difficulty. Let me see what's going on here.
While you're working on it, there you go. The objectives that we're going to cover today, we're not really going to talk so much about open education resources as we are going to, our objectives are to identify strategies related to learning outcomes and how do we measure learning in competency-based education. And then we will also discuss self-directed versus facilitated teaching practices for online education. And I think we're probably going to throw in a little bit of just classroom education as well. So first of all, what is competency-based education? There are all sorts of definitions. If you talk to some of the leaders in the field, they will tell you it's mastery-based learning. And we concur with that. It is mastery-based learning. It is, they'll say it's not bound by academic terms. And our position is it can be bound by academic terms. It doesn't have to be everybody progresses at their own pace. They will say that students will typically set their own pace of learning. And I think that's probably going to be true no matter what style of education you choose. Some students learn faster than others. Some get it early in the semester, some mid-semester, some it's the end of the semester. In competency-based education, many times they'll focus on one competency and then move to the next one. But we know in nursing and in education and in practice, you have to do more than one competency at a time. So that complicates matters for us. How are we going to measure multiple competencies simultaneously? And students are typically actively engaged with competency-based education. And we believe that's also true of nursing competency-based education.
So what does competency-based education mean for nursing education? Because as Denise was talking about competency-based education, it comes with some major assumptions that might not fit for the way in which we engage with our students and the current structure that we have in nursing programs across the nation. AACN has defined competency-based education as a system of instruction, assessment, feedback, self-reflection, and academic reporting that's really based on the student being able to demonstrate what they've learned in terms of the knowledge, attitudes, motivations, self-perceptions, and skills expected of them as they progress through their education. So it really comes down to demonstrating competency reliably in increasingly more complex situations across a variety of contexts. And for nursing, we do that within most of the time a semester bound or a quarter bound kind of structure. And so for us, looking at competency is really about what is the student going to demonstrate based on what they have learned. In terms of what it is and what it is not a checklist of tasks. It is not a one and done experience. So the student demonstrates it once in lab and it's done, or the student demonstrates it once in clinical and it's done. It's not isolated to one sphere or context in terms of patient population or in terms of setting. We are really looking at, can the student reliably across settings and across contexts demonstrate the behaviors that we expect of a baccalaureate prepared nurse upon graduation, or if it's a graduate program, it would be certainly at that level as well, the level 2. So it's also not demonstrated solely on an objective test. And a lot of the conversation has also centered around simulation, and that we can assess all of this in simulation. It's not about assessing it in any isolated environment. It's about looking at the learner across environments. The other piece that's really pivotal with concept-based education and the meaning for nursing is what we've borrowed from the larger definition of it, which is that it's learner-based, and that's such an important part of it. And this type of approach really clarifies expectations for both the learner and faculty, and it improves nursing education. And it also helps our partners and everyone be on the same page with what's expected of a graduate.
Many of the principles of CBE are things that we as experienced educators are already comfortable with, and those that we are mentoring our new partners in education to understand. CBE, just like any other good curriculum, uses effective sequencing. You identify your outcome, and then you design learning strategies to help move learners toward that outcome. You also design multiple measures for evaluating the desired outcome. That might include an objective test. We are bound by NCLEX, and we do have to prepare our learners for the NCLEX. So we are going to have to continue to give them written objective tests. But that doesn't mean that's the only way we measure the outcome. It might be that we measure one outcome through objective tests, through a skills demonstration. Then they take that skills demonstration and move it into a simulation scenario. After they've demonstrated competency in the skills and simulation labs, then we move them to a variety of patient care settings and ask them to demonstrate that same competency. And it might be something as simple as, or as complex as we learned yesterday, as doing nutrition education related to a diagnosis. That can be very complex, but yet we treat it as something that's relatively simple many times. Good competency-based education, and I think good education in general, involves active engagement. We have enough studies from decades past that show us that students remember more of what they do than what they see and what they hear. So we know that actively engaging them is vital to achieving outcomes. With CBE, it's something that we as the evaluators can directly observe. So the competencies that we identify require that it be something that we can directly see happening in front of us. Another key principle to CBE is that you do both formative and summative assessments of every competency. So every student gets the opportunity to practice and receive formative feedback before they're asked to demonstrate the competency for a true graded evaluation. And that requires a lot of effort on our part as faculty, because we're designing those formative pieces to build up to the final summative evaluation.
And along those lines with the formative assessment, one of the things that's so important is that we're giving frequent and timely feedback to students, and that in this model of competency-based education, the student is engaging in self-assessment, self-reflection, has the clarity of the expectations to be able to engage in that behavior, but that we are being very timely and very constructive in giving that meaningful feedback one-on-one to the student so that they know where they are on this journey of increasing in their development towards competency. And next, we're going to talk about some of the challenges of competency-based education. And there's quite a few questions up here. And we're going to talk about them a little more generally. One of the major challenges with competency-based education is that it really forces faculty to engage in backward design. So, and to conceptualize up front, where do we expect the new graduate to be upon graduation? What does that look like? Can we have clarity of that picture of what that graduate knows, what they value, what they're able to do with what they know in terms of skills and values and attitudes? What can they do with that? And what does that look like? So having a really clear picture of that, and then being able to progressively work backward to the very beginning of how do we then assess the student from the beginning all the way through and help them develop, give them that feedback that they need. Where are the measurement points? Where are the summative assessments where we're going to expect that the student can demonstrate this behavior or this action reliably in a number of contexts, etc. And so really being thoughtful at the beginning. So it puts a lot of work up front, and it can be very daunting for faculty, because when you look at the new AACN Essentials and you look at how many competencies there are, and you look at how many sub-competencies there are, and then you look at having to have multiple points of measure and multiple ways in which you're measuring that, it can seem rather daunting. And the advice is to break it down and realize that this doesn't have to happen overnight. And I'm confident that faculty are constantly assessing students and assessing them more frequently and often than they even know that they are. But this type of structure is going to enable the faculty to be more clear in their assessment and for everyone to be on the same page about what those milestones look like, and be more clear in their feedback for the student. The student is going to have clarity about where it is that they're going to eventually end up and have to be able to demonstrate, and that they're working towards that end goal. So when we look at some of these other questions, like what does competency and professionalism look like? When I talk to faculty, they say they know it when they see it, but sometimes they're not able to clearly articulate it. And so this really does force us as a profession and as educators to be able to articulate what that looks like. And in the AACN Essentials, they have the sub-competencies, which are the behaviors leading up to the competency that helps shape that. And professionalism is more than being on time to clinical or being dressed appropriately. And so there are sub-competencies in there related to advocacy and caring and ethical behavior. And so when we think about these things, I think a lot of faculty think about all the different pinpoints where those activities the student might have exposure to those activities in the curriculum. But really in competency-based education, it's about the student knowing what the behavior is that's expected, or the actions that are expected, or what the complete package looks like at the end, and then realizing and assessing themselves and engaging in self-reflection about where are they on that journey towards that ultimate goal. And so, you know, the question of how many times do you measure a competency to know that they're competent? There is no magic number of times. And it's going to be vastly dependent upon how the curriculum is structured and the opportunities that are available. It is completely possible to measure multiple competencies within one activity and within one kind of situation. But as I said previously, this is about the student being able to reliably, which means time and time again, being able to demonstrate those behaviors that we expect in different situations and different contexts, and also in increasingly complex situations. So what we expect of an entry-level student in their first or second semester of nursing school should be and is vastly different than what we expect of a student getting ready to graduate, in terms of how they're able to enact any given competency. If we think about doing a health assessment, for instance, we expect a first semester student to be able to do a health assessment, but they may need a checklist and a piece of paper, and they may need to do a history with a patient by asking each individual question. By the time they're getting ready to graduate, they should be able to elicit health history questions without going down a checklist of questions. They should be able to interact with a patient and be able to talk to a patient and garner the information in a much more authentic and genuine and conversational way than going down a rote list of questions. And so that's an example of how a student might progress throughout the curriculum and enact the competencies at different levels of development. Deciding where those assessments happen. Where is it most beneficial to engage in informative assessment that has to be timely and personal? And then where are those summative assessments that we need to do throughout the curriculum? How do we accomplish this within a semester? The answer is that this is something that's accomplished across individuals' program, but certainly within the semester constraints, we have expectations of where the student will be at the end of the semester. And so it's really about being very, very clear and able to articulate that and have everybody on the same page, including the student, as they're trying to accomplish that important work. And then how do we avoid that checklist mentality? Because we're nurses, and checklists are a part of our profession, but this really is about a bigger picture. And while we have to have a system to monitor the development of the student and document these assessment points, etc., the actual assessment doesn't come down to did the student just do this checklist, right? We're trying to have the development of a professional that is well-rounded and can embody all of these competencies in a way that isn't just a series of checklists.
So we're going to take a minute and I'm going to show you a course that we have developed here at Texas A&M University-Commerce. It's for our RN to BSN program, but these same competencies will apply to our pre-licensed program that is face-to-face. If you're doing it online, you have to make sure that you engage your students. That's critical. We know that. So one of the things that we worked with CBN, we've spent 2 years working with the CBN consultants. We worked with Learning Mate for instructional design for about 9 months, maybe a year. And we are almost through developing our entire RN to BSN curriculum under the competency-based model. We have 4 more courses to develop and launch, and that by May, we will have launched our entire curriculum under the CB model. So one of the things we've worked really hard to make sure in our online courses that we do is that we keep an instructor voice. So we talk to the students in print, just like we would if we were talking face-to-face. When we do the course overview, we tell them what the focus of the course is, how it's going to be structured, and what the focus of each of the modules will be. And then we tell them where to move to next. So we send them to the Start Here module. And through this module, we have if we redirect them back to the course overview if they haven't done it. We have a welcome module, and I am actually showing you our master course so that I don't run the risk of sharing any student information with you. The video is actually here. Our faculty who taught this in the fall actually created just a short, little over 2-minute video that she shares with students so that they get to know her as a person, and it helps them feel welcomed. Then we put the syllabus in this module, and she actually recorded a video and walked them through their syllabus, just like you would if you were in the classroom. But all of this is done asynchronously in this module. There's resources for students to learn how to use the LMS, and we still keep a few checklists, as you see. Have you done these activities? When we get into more of the content, we have a whole folder that tells them what competencies they will address during this particular course. We kept the course structure and the semester credit hour structure. And for us here in Texas, with our Board of Nursing rules and our approval, there's not much we can do that will move us totally away from that, at least not in a quick manner. It's going to take years to make those transitions, partially because of the amount of time and work it takes just to build one competency-based course. It took us I think it took us 6 months to come up with our own definitions, which is what you will see here. Under 1.1, Foundations of Nursing Knowledge, if you went to AACN's competency, this is not the definition you would see. This is our definition so that we know what we're looking for, and so that our students know what we're looking for. Because AACN did something we teach all nurse educators not to do, which is use verbs like understand, so that you can't, how do you measure understanding? You need a different verb to measure it. So we went in and we made those definitions our own. We then looked at the competencies that would be covered in our health assessment course, whether it be our pre-licensure or post-licensure. And we found that we mix competencies. So you'll see that in what we labeled nursing perspective, there are 3 from domain 1 and 1 competency from domain 4. Then in caring, relationship, and communication, we have competencies from 3 different domains, 4 different domains, I'm sorry. Domain 2, domain 6, domain 8, and domain 9. Nursing process has 2 different domains. Culture and diversity, again, 2 different domains. And then for professional identity, they're all from domain 9. So the students are given those competencies at the beginning. We also have levels of mastery that we chose not to share with the students because they can become rather overwhelming at this point in time. And then we set up our modules, and I want to show you a little bit about module 3. In module 3, we give an overview again, so you can click the module. That's not going to work today. Hold on a minute and let me go back, because it's asking me to sign in for something I don't have downloaded. They've updated it. We list the competencies that this module will cover, and rather than listing them out in detail, we just put the numbers. They can go back and pick them up. Then we have module learning objectives, and we tied those to the competency learning objectives. We have readings, and then because this is an online course, rather than doing a skills lab, we used Shadow Health for the demonstrations. And as you can see, I told you I was using our master course. We still had to list our competencies, which we did in the one that we have shared with students. So if we want to look at lesson 2, it is the I, and there are multiple images. We were able to use the ones from our textbook, which helped us out there. So that's a lot of static images, not a whole lot of interactive there. But if you go down to lesson 3, which looks at the ear, then we created a table so that it's easy for looking at the differences in the structure. They can look at the size of the passageway, what its opening is like, what the eustachian tube looks like, what's the stiffness, and what's the length. So at least it gets them involved. And we have some that are more interactive, but they don't always show well when I'm sharing a screen, so I didn't pick those. We have multiple hidden modules that are for the faculty. Here's another interactive that's embedded in the course, and ABCs of health assessment, so they can do flashcards, which again in the video in this demo are not working as they should. One of the options we chose after the first half of our first course was to change our grading. And because this is not a live course, you don't see this, but our grading scheme is color coded so that formative is one color and summative is another color. That way the students know what they must complete. Formative activities are optional. We stress that by doing them, they receive feedback that makes them more successful on their summative evaluations. Most of our summative evaluations, they're allowed 2, sometimes they're allowed 3 attempts. Right now, Remember, this is RN to BSN education, so we're sticking pretty much with 2 attempts on the summatives for the RN to BSN. Well, we're considering 3 in our pre-licensure. And so that's just one example of how we have put our course together. Each module has its own folder. We use D2L, and our students love the color coding that was put in because it helps them keep things organized. So, does anyone have any questions? I think that's the end of our presentation. When you see the slides that are shared, they will have references for where we found a couple of the pieces of information. Cynthia, do you have anything else you want to add?
No, I was going to go ahead and let me go ahead and advance it so they can see the references. They're the references that we had related to AACN and California Competes. I will say that the American Association of Colleges of Nursing have several documents that are really helpful and guidance on their website. There's a toolkit for competency-based education that's really helpful as schools engage in this work.
I think the biggest thing we learned is whatever you think it's going to take you to accomplish this work, double at least the time, maybe triple it. It is not something that's accomplished quickly, and the 1 semester applies not only for don't measure it in 1 semester, but don't plan on developing it in 1 semester either. I'm not even sure it's a 1-year project. I think it's probably at least a couple or 3-year project to do an entire curriculum.
Baby steps are okay.
And the competency-based learning model will help us to be more transparent with our students. You know, is it really fair to them to say, well, I'll know it when I see it, or you'll know it when you do it? We should be telling them, this is where you're going. Now let's work together to get there.
And I think that's one of the really beautiful things about this kind of structure is that it really puts the learner in active mode versus passive mode, and really helps us create a journey between the student and the faculty member that's a collaborative journey rather than more of an authoritative kind of positioning.
Thanks. This is Anthony. Hi. So Rebecca Witten had raised her hand, and if that is still good, maybe we'll try to unmute her, if that's okay, and then you could comment or ask, and then we are getting some questions in the Q&A. So Rebecca, you should be good to go ahead. And if it's answered in the meantime, feel free to say that too. You still are muted though. I'm sorry, you need to unmute yourself if that's not clear. Oh, okay, it was answered. All right, thank you so much. Okay, so then there are some questions in the chat, in the Q&A. One of them is from Christiana. I saw that you mapped the CLOs to the readings. Have you also mapped the CLOs for the assessment?
Yes, we have. And I actually have a really nice Excel spreadsheet, which will not show up on this screen, which is why I didn't share it, that lists our definition of the competency. Then we looked at, here's our definition. We created a needs improvement category. You know, they're developing, they aren't there yet. We've got a meets the competency category, and then it exceeds the competency category. And we actually have identified behaviors that address all 3 levels. And then we have also in that same spreadsheet listed measures that we use to measure that competency. Sometimes it's a paper, sometimes it's a interaction with a patient, sometimes it's something in our sim hospital, and sometimes it's a multiple choice exam or a written exam, but we do have them mapped. And our goal is to move that into the D2L shell so that the students will also see the mapping. Remember, I said this is not for the faint of heart, and it's not a single year process. So that course has only been taught one time. More of these things will show up the next time it's taught.
That's great. Thank you. There was another question from Carol. Were you doing regular curriculum while interfacing CBE?
We chose to pull out, we didn't have really any enrollment in our RN to BSN program the way it was offered at the time. And so we chose to pull it offline and not offer it for a year while we concentrated on developing the competency-based. But we are teaching our traditional pre-licensure BSN at the same time we're developing this. And one of the things that I did was hire recently retired faculty as subject matter experts to develop the competency courses, so that I didn't ask current faculty to do that on top of their work. Now, it's still all approved under our single curriculum committee, but it is two different working groups.
That's great.
I also saw a question in the chat about the progression indicators, and I don't know in the work that you all did, Denise, if you've already identified that. AACN has put together a working group or a committee that's really going to be gathering information from schools that have already done some of this work on progression indicators, and then providing more guidance surrounding the progression indicators. But there was a question on that. Did you all look at the progression indicators yet?
We have not as much because we've done this with the RN to BSN curriculum. We're just beginning with the pre-licensure, so we will have to do more work with the progression indicators with our pre-licensure students than we needed to with our post-licensure students.
And then there was also a comment about a mapping tool, a curriculum mapping tool. And I do know that AACN does have on their website guidance about curriculum mapping, and I'm not sure if they've posted a specific tool or not, but there is guidance about curriculum mapping.
There is, and the tool is similar to what we had developed before the tool came out. But what we did was we took all of the competency and sub-competency statements and developed the definitions all just on an Excel spreadsheet. And then we mapped our courses to those competencies, and we identified where we had multiple measures for a competency and where we had only single measures for a competency. And those gaps are where we began to work to fill in. And then we started looking at, okay, and we realized that we were doing more than we recognized as we started mapping it, because we were like, oh, well, this paper would measure this, and this paper, it would also measure this. So it gave us confidence that we weren't as far off base as it sounds like you are. And I think you'd probably all be in the same boat. It's overwhelming to think about changing a curriculum. I've been in education almost 30 years. I love curriculum development, but it is overwhelming to make changes. And so this is a huge change, and that's why I think we're all feeling really overwhelmed, but I know that we are more than capable of doing this work.
Well, and sometimes it's also about re-envisioning the work that we're already doing. So how do we take something that we've already done and then add some dimensions to it that will kind of flip the emphasis of it, so that we're looking at it more from a competency framework than from the framework that it was designed. So it's not about throwing everything out that you've ever gotten to a curriculum. It's really about looking at your curriculum in a more detailed manner and seeing if there's ways in which you can work with what you've already done, and then if there's ways to supplement that and be able to visualize where the gaps are and fill in the gaps, etc. So I don't want everyone to think they've got to throw out everything.
I totally agree. And what we have, the mindset we have adopted is concept-based curriculum and competency-based assessment marry very well together. And really, when we're looking at competency-based education in nursing, we've always been focused on competencies. We're just now focusing on how do we articulate those competencies more clearly for ourselves, our learners, and the people who we serve, the employers they'll go to work for, and the public that they will care for. So it's really not something we aren't already doing. It's something we haven't been articulating well. And the hard part is now taking that, I'll know it when I see it, and putting a detailed definition of what is it I'm seeing.
Right, and hopefully it bridges some of that gap of the transition to practice and where the practice sector expects the graduate to be versus where education expects the graduate to be. And one of the things that I applaud so much in the work that AACN has done is that they have made sure that we are engaging practice partners as we're having these discussions and really working together rather than engaging in the blame game about, well, the graduates aren't ready to jump in and practice, and education saying, well, we got them to a certain point and it's not about them being able to jump in and practice on day one. So I think that it really helps us all be able to transition graduates to practice and be able to give the care that we expect them to be able to give at the nurse preparation level that they're at, education wise, and to operate within their full scope of their ability. So
I think the conversations that are happening today between education and employers is very reminiscent for me of the conversation that happened in the late 2000s, 2008 to 2010, 2012, when we started really looking at associate degree to baccalaureate education and where could we as the two levels of education work more seamlessly together. And I think that this opportunity with involving our practice partners more in our outcomes has helped both sides see where we could improve. Where can we do a better job on the education side? And where is the practice side going to have to pick up because of restraints that they place on us on the education side of the house?
well, and certainly there's so much in education changing for us right now because of the type of learner that is coming to us and the point at which the learner is when they come to us and what their experiences have been prior to coming to us. So in terms of all of the students that were in school and in early parts of their collegial education during the pandemic, and how did that shape where they are and how they're coming to us. We've seen shifts in our learners. We've seen shifts in the repertoire of skills that they come to us with. I know that in the students that I interact with, we've also seen a shift in compassion, and there's some things that are really affecting them when they go into the clinical setting related to patient care and interacting with patients, and they're doing a wonderful job with caring and compassion and all of that, but it's also really affecting them at a very personal level that I think is a little bit different than previous. So we've got in all of this, not only to shift our focus for competency-based education, but really consider who is the learner coming to us, which is what you tapped into on part of what you said in the presentation, Denise, because our learners are ever changing. So it may be this way for the next couple of years, but then we'll get a different type of learner, and we'll have to be able to shift a little bit in how we interact and assess and create learning opportunities for that specific learner.
I see Karen ask a question about tracking and trending. What we're finding is that several of the majority of the students are choosing not to do the formative activities, and they're paying for it when it comes to the summative activities because their scores are not what they would like them to be. So one of the things that we are going to implement with our next rollout, which will be right after spring break with those courses, is an opportunity. We can't force them, but we're going to provide an opportunity for one-on-one or small group meetings with each of the students and the faculty. Right now, the enrollment's small enough we could do one-on-one to help them understand the value, hopefully understand the value of the formative assessments. Some CBE programs on our campus here, not in nursing, allow the student to take a pretest at the beginning of the course, and if they score an 80% on it, they can immediately move to the post-test and accelerate through that course. We aren't doing that because we don't have the manpower right now to do that, nor do we have the student volume to do that, because in order to allow students to accelerate, you have to offer every course every term. And we simply can't do that right now. We're too new in the process. So we've made the decisions that they can, and we don't have due dates in our assignments. We have what we call pacing guides. And those pacing guides are set up so that there are certain things that should be accomplished every week throughout the 7-week term if the student wants to complete the course in 7 weeks. Now, they may choose to do nothing for the first 5 weeks of the course and then take a whole week off work and do the whole course in a week. And if that's what they choose to do and they can demonstrate the competency, that's okay. If they choose not to do the work, then they must retake the course. Now, what we will allow them to do is pick up with whatever they had accomplished. If they had met the competencies up until week 4, then when they repay for the next term, they can pick up at week 5 and finish out. Does that answer the question? It's a whole different mindset.
Oh, she asked whether or not the students are liking that approach of not having deadlines.
They like it. Some of them are not doing very well with it.
I was going to say, we have a capstone course that has recommended deadlines, but they're not hard and fast. And we see the same thing. We see some students that finish up rather early with the modules in the course and get ahead of the deadlines. And then we see those that push it off to the end and then do a concentrated surge at the end to get everything completed.
I'm not sure what you mean by upgrading for papers. And we don't have a cohort model for our RN to BSN. We allow them to enter at any term, and they can either take 1 or 2 courses in a term. They can then take a term off, if life is happening, and then they can come back. We do have ungraded papers, yes, where they just get feedback. And the courses that have a major paper in it, there are usually small segmental pieces that are part of that formative assessment. Faculty will give them feedback on the paper pieces and then they do the final paper. It might be that one of the things they do is submit their references in APA, because we all know how students struggle with that. So.
See, there's a question about academic integrity issues. I'm not sure if
We have not seen academic integrity issues yet. And I say yet because there will be a time when they come. So. So we have policies for when they happen. We'll use the policies.
Crystal asked the question I was going to ask about. You know, academic integrity sort of might have meant something a little different in many disciplines until about last year, or year before. So, any determination, any way you can tell if they're using,
We
generative
do
AI?
have access to turn it in. We can ask, Chat GPT. Our campus policy is that faculty can make the determination based on the course or every assignment as to whether or not AI can be used in that assignment. And I've seen some work, and we're talking about it here on our campus as well, allowing the students to use AI and then asking them to personalize it. I mean, AI does some wonderful care plans, but then you need to personalize it to your own client. So I think it's a matter of us as educators adapting to the tools that are out there, rather than penalizing.
Well, and in reality, I see that nursing, even at the bedside, is going to be engaging in using AI for interacting with patients in terms of, generating a very specific diet for a specific culture related to, like maybe an ADA diet that's got very specific foods in it that's tailored to a client. So we have to be positioning students to be able to use it effectively. And they might use it in practice to solve problems or to be an aid to them in being able to advocate for patients and meet patients' needs, et cetera. So I think it's about leveraging it as a tool for that. It's interesting that you ask about AI because it just actually came up this week where I am, where students turned in identical reflections. And it was AI generated, and it was supposed to be self-reflection about something that happened in clinical for them, and it obviously was not personalized at all. It was very evident that it was AI generated. So I think faculty also being really transparent about what are the tools that students can use to aid them in doing assignments, where is individual student effort an absolute, and where is it not. And we face that even before AI because we do a lot of group work, so we have to be really careful about what is group effort and what is individual effort.
Well, and I think we need to look at it. The thing that really drove it home for me early in the AI conversation was we don't even think twice about letting students use a calculator on a dosage calculation exam. Whereas when I was in school, you didn't use calculators. So I think we're going to have to treat AI like we treat calculators. It's here. How can we teach them to use it effectively? I've seen that comment. The regular and substantive interaction with the instructor occurs through online office hours. It occurs through faculty feedback to the students on their assignments. Faculty reach out if the students don't seem to be engaging or are not making progress, just to check on how they're doing. We do it with in the competency-based courses, we do it just like you would in any other online course. They're not designed to be correspondence courses but yet they have that more of a correspondence component because they can progress at their own pace through the course. So it is a tightrope to walk with that.
Well, thank you. Anybody, not to cut it off or anything like that, but yeah, this, you know, this is a wonderful presentation, and the conversation in the chat and in the Q&A, it's really interesting. Like I said, you know, we have these just deep considerations and respect for all the effort that nursing faculty, department, you know, coordinators, course designers, you know, put together. And like the more and more sessions we attend, it's really evident how complex it is, and so on. And you know, there were some questions, you know, earlier on about remixing and using the materials. You know, this wasn't necessarily on that, but I will say, you know, we're very glad, and it, you know, this isn't a promotional thing. You know, it's really just about fostering discussion and engagement. And I know that the THCCB and Openstax itself, you know, glad to foster those discussions, create workshops, environments, places where we can do that, so that we can do that. And other folks are too. Whisk Tech was mentioned. We work really closely with them. We're actually putting together some workshops where we'll collaborate with them and the OpenRN folks and things like that. So it's really a growing arena. And I know that just not even on the OER front, but on the CB front, and different organizations are working on that. We do have another person who just raised their hand, so I'll allow them to talk. What we'll do in the meantime, we will put it. We're not going to have to end this or anything like that, but we will put the survey in the chat. But Casey, feel free to go ahead. You have to unmute yourself though too.
I want to add one thing. I know that last spring, was it, Cynthia, OLN from the Organizational Leader Network with AACN did a webinar on AI and Chat GPT. And it should be in the archives for AACN if anyone wants to go back and watch that webinar.
And the other piece with that webinar, and I've clarified this with AACN, we wanted to broadcast it as a faculty development workshop. We do monthly lunch and learns for our faculty, and so you can play it and use it and broadcast it like to a faculty group, etc. It doesn't violate anything with AACN. It's free.
Casey, if you want to ask your question, just unmute yourself and feel free to go ahead.
I'm sorry, I did not mean to raise my hand.
Oh, okay, sorry.
I don't have a question.
Okay.
We, Nikki, you asked about how we're attributing it to faculty workload. Are you mean teaching the courses, or you mean developing the courses? Because there's two different aspects there.
I was gonna say I can go ahead and speak to developing the courses. We have quite a few committees that are doing this work within the committees, and our faculty are given 10% effort towards service. So their service on that committee is being provided workload credit for doing that service. On occasion, if I have a specific faculty member that's engaging in significant curriculum work, I can also assign workload for it, but we really try to do it within the committees and for that service workload credit.
So you're asking about teaching. So right now we're still doing it in the same model that we use for our traditional workload by semester credit hour. It's self-paced, but students can accelerate. Now on our campus, when we ever get to the point that we offer enough courses that they can accelerate, the way our campus is working it, and I think we would probably adopt the same model, is you get paid based on the number of students enrolled. And there's a cutoff date beyond which you can't add a new course each of the terms. So the workload is attributed that way. And most of our competency-based courses are taught by long-term adjuncts, because balancing this people dropping in and out of courses with, or that's the only thing they teach in is the competency-based courses. It's difficult to do it with a traditional semester course and these courses balancing.
Well, again, thank you all. And I'm glad the conversation has kept going. It's been a lot of work for Cynthia and Denise to put this together, and not on the longest notice either. So thank you again so much. Uh, it's just the intersections of a lot of support and effort. I will say, talking to some folks, the AACN about the conference, they said you should have Cynthia speak at your conference, and then Denise has been one of our greatest advisors for the entire program. When we started off yesterday, Carrie and I shared. Denise might not even know the import that she had, but really just talking about, I'm sure all your faculty will appreciate this, like just the challenges of being a faculty member facing, differences in employment in nursing and nursing education, retirement cliffs and staffing differences and all the complexities. And every discipline faces it. Openstax, we've been involved with a lot of different disciplines, bio and math and physics and American government. Everyone has their challenges. Nursing certainly does too. It seems a little more, seems like you all have a lot to worry about, like we've been saying. So, and of course we knew that, but it's certainly a challenge. And having presentations like this to share information, foster knowledge, think about how you all support each other is wonderful. So thank you. So just for some logistical elements, so we have another session starting off actually I'll before I say the wrong thing, at 10:30 Central. That's 10:30 Central, 11:30 Eastern. That's going to be on the social determinants of health and nursing education workbook. It's by Carla Kirkove and Dawn Bowker from Iowa State. And they've created a workbook on incorporating social determinants of health across different elements of the nursing curriculum. So it's not specific to one book. One course. So that's an interesting one. It's OER. It's not part of the one program specifically, but it's OER and can be used and remixed to the conversation that we saw happening. Please join. The rest of the day, we have other presentations on the other textbooks in the program throughout the day. And then we have a networking session, which is in the middle of the day, you'll see on the schedule, where everybody has the opportunity to sort of workshop and share ideas. And at the end of the day, Christy Bowen from Midwestern State is going to be talking about overall implementation of the resources involved in the one program. So that's the rest of the day. Please, we just so glad everybody's joining. The engagement has been wonderful. Seeing all the chat activity, seeing people who got to know each other come together, and share ideas and so on. And then some folks who don't know each other, same thing. So it's just great. Again, Cynthia and Denise, thank you so much. Any final comments or anything we should keep in mind? Or
I just want to say thank you for the opportunity. It's always wonderful to dialogue with other people about this topic. So thank you so much.
Great, thank you.
And I echo that. Thank you for the opportunity. And I think that together we are stronger, and we need to have more of these kinds of conversations so that we learn from each other.
So great. Thank you so much. That's wonderful. That's a great thing to leave on. So thank you. Everybody, again, thanks so much for joining. We'll see everybody who can join back. And these sessions will be recorded, posted to the YouTube channel. Anything else you'd like to discuss, we'll be around to talk about it. So thanks so much. Have a great day.